if we don't have the film ready, I can just kind of improv. I'm Jeremy Abbott. I'm the VP and publisher of Scientific American. I'm de facto MC today, and I'm going to be doing a panel or two. Welcome to the Patient Summit. It's just amazing to see everyone here. I myself am someone who is just day in and day out dealing with communicating science to the public, and it's amazing to be in a room full of people that not only believe in science, but use it to help people every day. And I've been at this forum for many years. For a while it was virtual. It's amazing to see a live event. There's nothing like a live event. There's something called the shopping cart phenomenon. I don't know if anyone knows what this is, but you're driving in your car and someone cuts you off and you're just like, that person, and you're all upset. But if the same thing happened when you were in the grocery store and you were pushing a shopping cart, you'd say, oh, sorry, excuse me, I'm so sorry, my fault. Dealing with people live is just an incredible way to experience a shared humanity. And I just love live events. I've met a lot of you, a lot of people here I've met on screens, and for the first time I'm seeing them in 3 dimension, and it's just amazing. And when I think about what happens when we share humanity, it fuels us to care about each other. And that is such an important aspect to what we are doing here. We are taking the lens on science and innovation and projecting it on the most valuable part of this equation, which is the patient. So I'm just thrilled to be here. I know, Eduardo, you want to make some opening comments, but I figured I'd start off. So Eduardo Komen, I'm so pleased to be this amazing forum.
Thank you, Jeremy. Thank you so much. Thank you for being our amazing moderator. Good morning, everybody. First of all, I'm glad everybody could pass the security check. So today marks a historic moment for the Galien Foundation. For over 50 years now, we have recognized scientific excellence in the service of human health. Today, we take the next step by creating a platform where patient voices directly shape the future of medical innovation. The summit honors the legacy of Professor Elie Wiesel, our honorary founding president and Peace Nobel laureate, who dedicated his life to education, compassion, and human dignity. His spirit guides us as we embrace the fundamental principle for this summit: no decision for me without me. I want to thank you, Jeremy Abbott, Vice President and Publisher of Scientific American, for moderating today's event. And lastly, I want first to congratulate for his Startup Award for Resuscitate this morning, and welcome our dear friend Thomas Lyons to join me on stage.
Thank you, Edward. I was going to say distinguished guest, but in America I say, hello, guys. It's both an honor and a privilege to open this first Galien Patient Summit. At the same time, it's a humbling experience because what Galien does is it gives a voice to people that normally wouldn't have and rewards those people who help the people who need a voice. For myself and all in drug development, patient normally means someone we treat or we plan to treat, either with existing drugs or drugs in development. As an industry, we generally think that we know what is needed, and the patient is subservient to our ideas and financial considerations, and therefore should simply accept how we treat them. The fact is that the patient is what this whole industry is about. And the patient needs to have a real and audible voice. This doesn't just mean meetings between industry and patient advocacy groups, but true collaboration. By true collaboration, I mean industry listens, industry works together with patients to understand their real-life experiences with their disease or condition, and industry works together with the patient to find better, more efficient, more affordable ways to deliver drugs and other treatments in a way that redefines the industry-patient equation, not relationship, equation. A patient, to me, is a partner in what we do, regardless of their color, creed, gender identity, religion, political affiliation, or financial situation. We must not discriminate between the patient that brings $100,000 a year for a fancy cancer treatment or one who brings $500 a year for what we in the industry tend to believe is a lesser condition. Pain is pain, all blood is red, and every patient counts. We have an obligation to manage drug costs to patients better, to include more diversity in our process, and to work together, hand in hand, industry and patient, to find the clinical solutions needed, especially for diseases affecting the less fortunate, including, but not limited to, sickle cell disease, where we have 100,000 patients in the US and 60 in Europe, and there are 8 million patients we don't give a damn about, and diabetic foot. So how to advance? Both sides, patient and industry, should listen, discuss, share ideas, and work together to change the relationship between industry and patient so that the term drug supplier ceases to exist and partners in treatment replaces it. This togetherness agenda is what is needed. It's our responsibility and should be the mission of all of us to advance it. We've all heard the term, Rome wasn't built in a day. But let's make this day, the first day of the Galien Patient Summit, a beginning of a new industry-patient relationship structure. Thank you.
We're going to show the film. Is that correct? Short film, and then we'll do our first panel. It's a real cliffhanger. Without further ado, I'm going to introduce our first panel to kick off this amazing convening, transforming innovation into patient outcomes, grounded in community, guided by science. This is probably the best way to kick this conversation off. I'm going to introduce the chair of this. Katie Mazuk is Chief Patient Experience Officer for Novartis, and I just learned she grew up like 3 miles from me. So take it away, and I think before we start, we're going to introduce our patient voice before that.
Hello? Okay, yes, thanks. Good morning, everybody. Along with my esteemed panelist here, who I'm going to introduce in a second, we're thrilled to kick off the inaugural Galien Patient Summit. It's just an honor to be here today. So I'm going to quickly introduce my esteemed panelist. So first, on my left, is Dr. Mike Hodin, who is the CEO of the Global Coalition of Aging, which is a global lobbying organization on age-related policy and market-based solutions. Dr. Hodin is also a managing partner at the High Lantern Group, a fellow at Oxford University's Harris Manchester College, and a member of the Council on Foreign Relations, and an advisory board member of the Milken Institute Center on the Future of Aging. Welcome, Dr. Mike.
Except it's not a medical doctor. It's a PhD in political science.
Amazing. Our next esteemed panelist, Molly Guthrie, is the Vice President of Policy and Advocacy at Susan G. Komen, which is one of the country's leading breast cancer advocacy organizations. For more than 20 years, Molly has worked in public policy and community outreach in the nonprofit sector and has advocated for health-related causes. Welcome, Molly. Dr. Uché Blackstock is a former NYU Langhorne physician and is the CEO for Advancing Health Equity, which is a healthcare consultancy focused on embedding equity into many different clinical settings. Dr. Blackstock is also the author of the New York Times bestseller, Legacy, A Black Physician Reckons with Racism in Medicine. She's a contributor on MSNBC and NBC News. Welcome, Dr. Blackstock. And finally, John O'Brien is the president and CEO of the National Pharmaceutical Council, which provides public or policy-relevant research on the value of scientific study and patient access to treatments. Prior to joining the council, John held senior roles in the life sciences and managed care industries and has served as a senior advisor to the U.S. Secretary of Health and Human Services. Welcome, John. Thanks. All right, we're going to start this panel the right way, the way we should on the Galien Patient Summit. So we're not going to start with my questions. We're going to start with a patient question. So Chris, would you mind standing up, introducing yourself, and give the first question to the panel?
Hello, everyone. Thank you. My name is Chris Williams. I'm the CEO and founder of Heart, Body, and Soul. It's a Brooklyn-based nonprofit focused on Black men's health. So I'm also a 4-time heart attack and cancer survivor, so I know a few things. So as someone who's lived through multiple health crises, I've seen innovation in medicine move fast, but unfortunately not always reach the people who need it most. How can we ensure that these innovations are truly accessible and affordable for the communities most impacted by health disparities?
Thank you so much, Chris. All right, panelists, who wants to go first with Chris's question? John.
Well, I'll dive right in and first say thank you to Edward and the forum for having us, and to note that the first patient summit was standing room only before the panel started. But great question. I'm a pharmacist by training, but I've also been a caregiver to two parents in their health and cancer journeys. And what brings me to work every day is that there are three things that stand in the way of the patient access that you described. First, we no longer view medicines in this country the way a patient would, something that helps them get well, stay healthy, and ultimately avoid more costly or cumbersome care settings. Instead, we have a system of middlemen with perverse incentives that view medicine as an arbitrage opportunity and seek to extract margin from the price of the medicines. That causes problem two. Problem two is when a patient goes to the pharmacy counter to pick up their prescription, they're faced with a high out-of-pocket cost because of all the money that has to flow to the perverse incentives in the system. More than half of what we call drug spending in this country is going to someone other than the company that discovered the medicine and brought it to the patient. And all of that adds up to patient dissatisfaction when they're being asked to pay a high out-of-pocket cost at the pharmacy counter. That supported 30 years of political pollsters telling politicians that they need to focus on drug prices. And what that leads to is a series of bad policies, or policies that really have the potential to affect innovation. And when I look at the passage of the Inflation Reduction Act, I think first, it's a godsend to the 3% of patients who have out-of-pocket spending above that $2,000 out-of-pocket cap. So I'm glad that my mom and people like her won't have to pay 5% forever in their Part D drug benefit. But we're also seeing that the Part D market is going to have fewer health plans. About a quarter of patients are going to have to change health plans. Many of those plans will have higher out-of-pocket costs and higher deductibles. And because of the perverse incentives in the current system, the rebates that will no longer be paid on the drugs that have a maximum fair price, we're not sure that patients are going to get access to the medicines for which the government built this incredibly complicated system to set the actual price of a medicine. And when you combine that with the fact that we're already seeing a reduction in the number of drugs with one indication being studied for a subsequent indication, or the number of treatments that can help people living with rare disease pursuing a second orphan designation, I'm just concerned that the way the money flows in this system to people who aren't doing the work of drug discovery and serving patients is leading to patient out-of-pocket costs that continue to rise, which supports the proliferation of bad policies that harm innovation.
Thank you, John. Other panelists?
Yeah, so I'll go. So, obviously, as John mentioned, cost is a huge issue. I think for me, in terms of the work I do, trust is a huge issue. And we're seeing that, more and more now. I always talk about, and I wrote about this in my book, a personal story of my barber, who I've known for about 20 years from when I used to wear my hair very short. And I saw him on the street in 2021 in our neighborhood, and he said, Uché, I need to talk to you. And I said, about what? He said, the COVID vaccine. And he said, I see you on MSNBC. I see Dr. Fauci on MSNBC, but I know you and I trust you. And he says, I don't have a primary care physician. I don't have insurance. And I need to ask you some questions. And so we talked on the phone for about an hour, him and his adult daughter, who also had a lot of questions. And 3 weeks later, he went and got vaccinated. And I remember in that moment being so happy that I could be there for him, but also feeling profound sadness that he was not connected, did not have access to a healthcare professional who he could really talk to and trusted about these concerns. And so sometimes I think about, what's the point in having these innovations if people are not able to access them because cost is one issue, but trust is another issue. And so I see that's about relationships, right? We talk about hesitancy, but it's really not hesitancy. It's about history, right? And what's happened historically, but also what happens contemporarily when people interface with the healthcare system. So, those are things that I think about in the work I do, thinking about how do we embed equity into the DNA of how systems work in terms of care, leadership, and accountability, because I think innovation, it only works when people believe it was created for them, and when they can afford access and trust it.
I love that. That intersects, two topics of both trust and then also access to healthcare, access to local physicians. I know the statistic now is 1 in 5 Americans actually do not have access to a healthcare provider, and that's a big part of the trust equation too. Great. Molly, I'll go to you, and then Mike, we'll go to you.
You picked the wrong seat. So as Katie mentioned, I'm with Susan G. Komen, and our mission is to end deaths from breast cancer, and we do that twofold. One is investing in doing our own research to advance the cures, but the second piece is ensuring access to high-quality care for all people. And the reason that we focus on that piece is our advisors tell us with just what's available today on the market and screening and treatments and access to care, all of those things, we can reduce breast cancer deaths by 1/3. So we don't need we do need new innovations, but we can bring down the deaths just by getting people access to care. And so it's a fabulous question. Thank you for asking. I feel like it's 99% of my life working with state and federal governments on how we break down these barriers to ensure that people have access to innovation. I would take it up even maybe a higher level in the environment that we're in right now and the landscape that is coming up. Even access to health insurance is a massive barrier. We're anticipating more than 10 million people are going to now be uninsured because of recent changes to health policy. So to your point, right, if we don't have access, if there's not trust, innovation doesn't really matter because people aren't going to be able to get to it. For those that do have health insurance, it's not a magic solution, unfortunately, and what we hear far too often from patients are a lot of processes that are put in place by insurers to make it challenging for them to be able to access the treatments that they need. In the policy world, we call it utilization management, and there's a ton of different examples. But one recently that's on my mind, I spoke to a woman yesterday living with metastatic breast cancer, and she's fortunate. She's still able to work. She has private insurance. She has treatment that she's responding to. But in the 4 years that she's been living with metastatic breast cancer, she's had to change insurance providers 3 times just because of her employer has changed their provider for the organization. And every one of those 3 times, she's had to go through a month, 2-month, 3-month-long process to validate the fact that she's been stable on the medicine and that it needs to be covered, and this is what she needs to have access to. And so really, unfortunately, from the patient's side, it's kind of endless barriers to treatments. And I agree completely. There's no value in innovation if it's not actually getting to patients and all of the patients that need it. So there's a lot of work to be done, and again, a lot of time on Komen Center for Public Policy is spent ensuring that all people have affordable access to the treatments and the innovations that are out there.
Thank you so much, Molly. I know we were talking just even last week, right? With the early detection in breast cancer, we have a 99% survival rate. Like, it's incredible. Innovation's amazing. Yet 1 out of 2 women are not getting their annual mammogram, and it takes early detection to get that innovation there. So really critical pieces as well. All right, Mike, what are some of the barriers you see?
So I was going to actually pick up exactly on your point. In addition to not being a medical doctor, the Global Coalition on Aging is, as the name suggests, a global organization. We operate around the world, and through the lens of the aging of society. So let me make a few points that are from that perspective, which maybe reimagines the question, if I could. There are about 2 billion of us on the planet today over 50, and tens of millions in America. And a vast majority of us over 50 have different elements of health conditions that are different than when we were 20 or 30 or even 40. And many of us are patients, and many of us don't think of ourselves as patients, but nevertheless need to have access to addressing these health conditions in order to have the early detection, diagnosis, and treatment that we've been alluding to. And a core element there, which has already been mentioned a couple times, is trust. Because it's not only the access to these early detection, diagnosis, treatment, but it's the trust to be able to actually change your behavior. And I'll talk about this a little bit later, but we have a program with Novartis Pharmaceutical Corporation in Baltimore called Engage with Heart. And trust is actually at the center, which changes behavior, that gets to points around adherence and compliance. So you can have all the access in the world through even lower prices, which may have an adverse impact on innovation. But even if you did that and people are not complying or adhering, it doesn't work. And we see that around the world, from Japan to many European countries where you have national health services, and you still have very low adherence and very low compliance. So I think we need to reframe this in the context of not so much the absence of disease, which is the way 20th century healthcare and medicine thinks about it, but functional ability, which has been reflected through this decade of healthy aging that we're living in. Our functional ability to do what we want, whether we consider ourselves a patient or are in some status of a health condition that might be different than we were 25 years ago and needs a change in the kind of foods we eat or a medicine that we take. So I think the access in that sense is a little more complicated and goes to the heart of how the 21st century is really changing it because of longevity.
Love that, Mike. And Chris, thank you for opening us up. I think we got a good understanding, unfortunately, of the barriers we're facing that are quite broad for health access to innovation. But we're going to start to pivot into some of the solutions, what's working and how we're measuring impact. So John and Uché, I'm going to start with you guys first. John, first you. We know that we've just heard and we've talked about that many health concerns require supporting patients with not just their medical or their clinical needs, but broader needs, non-clinical support. I want to know more about how your specific organizations are doing this and advice to this audience about what more can we all be doing. So John, I'll start with you.
Thank you. Before I answer that question, can I just tell you how cool it is that you have the title that you do and recognize Novartis for walking its talk and having a Chief Patient Experience Officer on its leadership team?
Thank you. Appreciate that.
So I lead a research organization, and we serve patients and society by conducting policy-relevant research on the importance of patient access to innovative medicines and the importance of protecting scientific advancement. And I have a fantastic team of health economists. And those health economists remind me that all too often when people are measuring the value of a medicine, they're forgetting the non-clinical aspects of that medicine. Sure, you can do just a total cost offset calculation, but if you're ignoring what it means to a patient's quality of life, if you're ignoring how a medicine reduces caregiver burden, or the fact that a parent has to be away from work so that they can care for a child who is being treated, if you don't recognize the value of those non-clinical elements of value, then your estimate of the value of the medicine is incomplete. And all too often, we are running into a growing reliance in the United States of health technology assessments that come up with a really strong statement and a really strong statement in the executive summary, but they don't expound to the media and others what's contained within that detailed methodology. And if someone who's evaluating the value of a medicine is ignoring all of those important non-clinical benefits, the way that a patient or caregiver's life is actually changing beyond just the treatment cost offsets or the clinical outcomes, then they're telling an incomplete story. So the research that we do with the team of health economists that we have that view medicines the way a patient does is how we continue to push back on those that want to only tell part of the story. And if you're invited to speak to a state, if you're invited to speak to a health technology assessment organization, being able to speak to the importance of including all of the non-clinical or novel elements of value that may not be included and how important they are to you as patients is one way that we can work together.
I love that, John. The encouragement to really actually measure the whole value that the therapies are providing and speak to that. It's really important.
Yeah,
Dr. Blackstock?
Yes. So I come from this perspective, having been a patient, but also as a physician, as a second-generation physician who, saw my mother and her colleagues in the 80s and 90s working just across the river in Brooklyn and in Crown Heights, sort of addressing the needs of their patients, not just clinically, but non-clinically. And I have to say that over my journey as a health professional, I've had to unlearn and relearn some things. So just for context, in medical school, there's a lot of emphasis on the dyad of the patient and the physician. And so we get this idea that everything that impacts the patient happens within that exam room. And that's not true. It's actually who's in the exam room with you isn't just your patient. It's their family, it's their neighbors, their community, their employers. And so, often we've talked about this idea of like culturally competent care, of having to understand the culture of your patients. And I think we're shifting away from that now because that's sometimes turned into stereotypes about different groups, and really thinking about like what is structurally competent care, right? How is understanding, at the very least, the barriers that your patients are facing in their communities. Oh, okay. Yeah, at a community level. And so, we're thinking about food insecurity, right? We're thinking about housing insecurity. And, we're not expecting clinicians to be able to solve all of those problems themselves, but at the very least, they should be able to assess for those issues and connect patients with the resources that they need. And so, I can tell my patients, eat more healthy, make sure you work out. But if they're living in food deserts, if there is no green space in their neighborhoods because of the legacy of redlining, and if they are living in pharmacy deserts, then that is going to impact, their access to ultimately to the medication that they need. And so, with us at our organization, Advancing Health Equity, we're really about making sure we're teaching clinicians, health systems about empathy, communication, cultural humility, really having a more holistic view of what health looks like, and that it's not just what happens in the exam room, but just having a broader understanding of what's happening just at the neighborhood level for your patients.
Yeah, I love that. Expanding the role and the responsibility of the medical community in non-clinical barriers is really critical as well. Excellent. All right, I'm going to turn to Mike and Molly, which I think is a TV show, right? Mike and Molly. As I said it, I went, oh. But for our third question, related to, we know your organizations are doing a lot of work in prevention and longevity in local communities. So curious to hear more about your organizations and what you see the role of awareness and screening, helping patients get the health they deserve, the outcomes they deserve, and how we can do a better job of driving these types of prevention and detection tactics for the communities we serve. So, Molly, you want to go first or second?
I'll go first. Okay. And hopefully can avoid another coughing attack. So I imagine everyone in this room is familiar with breast cancer. We've done a great job of awareness of the disease, but we are still losing 43,000 women and men to this disease in the U.S. every year, and more than 340,000 people are going to be diagnosed. So there's still a lot to be done. And as Katie, you mentioned earlier, I think everyone has also had hammered in their head that, go get your annual mammogram at 40, that's when you have to do it. But it's still about 50% of people actually going to get that screening mammogram. And so there's still a lot of work to be done. We as an organization do a lot around awareness and education to get that messaging out. But in the policy space where I work, it's not as simple as that. There are a lot of barriers that exist that we've already spoken about today to getting access to high quality screening. And that's for just people at average risk. So if you layer in people that are at elevated risk, we've made so much advancement in understanding this disease, the types of disease that make up breast cancer, and the risk factors that contribute to the likelihood of getting breast cancer. And so through that risk factor analysis, you're able to determine if maybe you're not someone that just needs your screening mammogram at 40. Really transitioning to that personalized medicine and personalized care and getting the right care to the right person at the right time. Unfortunately, that's not how our healthcare system or our policy governance is set up. And so screening mammography is covered at no cost for women beginning at age 40, and now it's back to being annually. But if you need follow-up imaging, say that screening mammogram came back suspicious or there was a question and you need an ultrasound to follow up on that, that diagnostic imaging, while covered by most insurance, comes with significant out-of-pocket costs for patients and creates a barrier to that earlier diagnosis, to that prevention. But then going back to that risk factor piece, if you're found to be at high risk of breast cancer, a screening mammogram might not be the right solution for you. And you might need that beginning earlier than age 40. And that supplemental imaging, again, while covered by insurance, comes with significant out-of-pocket cost. And we know anytime cost is introduced into the equation, adherence and utilization goes down. And so we've been working, now, probably for 5 or 6 years to address this via policy, to work with our policymakers at the state and federal levels, to change requirements of insurance companies, to look at that cost-sharing continuum and completely eliminate the out-of-pocket cost for that diagnostic and supplemental imaging. We've had great success at the state level. We have now more than 30 states that have these laws on the books, which is a good accomplishment, but only impacts those that are on state-regulated health plans. And so we've been working since 2019 at the federal level to try to get this to advance. And I think it's well covered now for the last, 29 days, that there's not a lot of collaboration between parties, but believe it or not, that existed for many years before. And so it's been a struggle to really get a common sense policy to move forward that's really gonna not only save lives, but draw down on healthcare costs for individuals and for the system. So trying to find solutions, we were really excited to partner again with Novartis earlier this year to launch the Alliance for Breast Cancer Policy. And the Alliance is the first alliance and coalition, which also kind of blows my mind, that brings together all of the groups invested in the breast cancer policy access space together to speak with one voice. It includes patient groups, it includes providers, it includes our pharmaceutical partners who are an important part of the conversation, again, to bring everyone together and demand change holistically. And so the number one priority of the Alliance is getting this federal legislation passed and enacted so that no woman or man that needs breast imaging has to pay out of pocket, because we know, as Katie again mentioned earlier, when we catch cancer earlier, it is, for the most part, a survivable disease. And the cost is less, again, for the individual, outcomes are better, and it draws down the healthcare cost, across systems. So, it's a struggle, and I think for breast cancer, many people think, we've addressed this, we found the solutions, let's move on to something else. And we have this level of struggle in the breast cancer space, and it's unimaginable the other diseases, the other cancer states that don't have these prevention and early detection tools. And so just, again, emphasizes the importance of innovation, and when those screening tools or remedies do come to market, that there is that access piece too, so that people can actually utilize it.
Yeah, I fully agree, Molly, and that just also talking about that policy has to have a big role as well as in prevention, detection, and moving this forward for many patients who may want to get screened, who may actually get the request from their doctor to go for the additional detection and screening, but can't at the end of the day. So a great one. Mike, how about you? Prevention in local communities, longevity in local communities, how are you going about that?
Yes. So let me make a general point and then two supporting points around this. One is, there is no question that in 21st century America and everywhere else around the world, we must transform from the 20th century acute care model to a 21st century prevention model. We have to do that because we can't afford not to. And so that's my first point I'm going to give you at the macro level, and my second point at the local, community, individual level. The macro level is that it is an economic point. It's not a healthcare point, it's an economic point, it's a fiscal sustainability point. And we should have, at the public policy level, Treasury secretaries, ministers of economy, as interested and promoting this as ministers of health or others in the healthcare community. Because otherwise, in the context of the 2 billion of us doubling over the next couple decades, so up to 4 billion on the planet, over 50, we must get to the place of investing in and spending on prevention. But we have to give the economic analysis that gets the support for it, and also in the workplace. So businesses have as much of that. Secondly, at the individual level, how do you get there? And this Engage with Heart program we have in Baltimore, as I've already said, which is our partner is Novartis in that. But the real partner, or partners, are the local community leaders, and principally two, the African American churches in Baltimore and the age-friendly community centers that are part of the political, the mayor and the governor. And what we did with them was to essentially go in literally into the pews and find people who wanted to become community health ambassadors. This is our terminology for a community health worker. It's a little bit different, but more or less the same model. And through these community health ambassadors, I think we are creating a new healthcare delivery model, because Mrs. Smith, at 78 years old, will listen to Jessica, a community health ambassador who is trained on what she should do with respect to prevention, or then if something happens, what she does about her particular condition. And we're finding that it is, and we've all said it, it is, at the center, it is that trust. It's the trust that came to them through the community center and the churches, and in particular members of their community who are, I mean, ultimately you need, obviously, the healthcare community, the professionals, doctors, I mean, there's no question about it. And we're actually working with, for example, Johns Hopkins, University of Maryland, but you don't get people behaving the way we want them to behave, the way they should be behaving for their own interest, if there isn't that level of trust, which then leads to their engagement, which leads to the change. And we're seeing that in great sense in Baltimore. And the final point I'll make, which is coming back to the macro level, which may surprise many of you in a session on patients, one of the most, I think, important statements in this space around prevention came in April of this year at the IMF World Bank meeting, where the IMF had its outlook report, and it said, we have some economic headwinds globally, including here in America, and one of the key headwinds is the aging of society, and the answer to that is to have people working longer. But the only way they're going to work longer is if they're healthy enough to work longer. And the only way they're going to be healthy enough, this is in an IMF report, International Monetary Fund, is to have spending on investment in prevention and health promotion. So I think we've got the basis of this through this lens of aging, but it all comes down to these community health workers in our Engage with Heart program. And I will tell you that in America, we try to do health reform. It really isn't health reform, it's healthcare financing reform. We don't do that very well either. But we've never done healthcare reform, health delivery models. And there are examples around the country and around the world, and one of them is in Baltimore that I think we could learn from. We need a shift in health care delivery, and healthcare delivery not just when someone's sick, but before they get sick. Sorry, that was probably too much.
No, it's great. I would appreciate it, Mike. And our philosophy is that with community-led health work, it should be led by the leaders of the community. And we are really excited about efforts that are sustainable and scalable, but it's got to be community-led, community-centric around that. So, all right, I'm going to give you guys a quick hit question because we need to give it back to the audience for their questions to you. So all of this also matters in how we measure this impact. So I want you guys to give me one quick answer about how you're measuring the impact of getting innovation ultimately to patient access in your organizations. Just a quick hit on measurement and how you're measuring the impact and the progress we're making.
I'll start.
Please.
Engagement. We're measuring in Baltimore and other models like this that we're working with around the world. So it's not just here in America. It's engagement.
Awesome. Molly, how are you measuring impact?
We measure impact on a lot of levels, but continuing the conversation that I started around access to screening and early detection, one key measurement there that is tracked is early stage versus late stage diagnoses. And so trying to shift to a higher number of early stage, especially when you look at Black women in that population, it is drastically worse for late-stage diagnosis and outcomes. So shifting as much to early stage as possible.
Okay.
So
Dr. Blackstock.
advancing health equity, like we're really asking the question about, are we measuring what truly matters to patients? Because often what we think are the metrics are not the metrics, right? And so one thing we do is community impact assessments, where we combine quantitative data and qualitative insights from the community through surveys, through listening sessions, and through focus groups. And we really want to know about, what their care experience is like. Do they feel respected, heard, appreciated? Are those interactions, dignified to them? Because I think those are the real indicators of, of whether change needs to happen.
Awesome.
And, I think about my mother, who at 47 was diagnosed with acute myelogenous leukemia. And, she, as a physician, she became a patient. And she said one of the hardest parts of becoming a patient was learning to trust the system. So that reminds me that like every patient that walks into a clinic, it's an act of faith for them.
Amazing. All right, John, how are you measuring impact?
We envision a world where prescription medicines are accessible to patients, valued by society, and sustainably reimbursed to ensure continued scientific advancement. We support that mission with research. Every time a member of the patient community cites that research in their comments to the Medicare program or to state policymakers, every time a member of Congress decides that they're going to cite that research when they open a hearing, or more importantly, advance policy that walks back things that punish companies that develop medicines for people living with rare diseases instead of rewarding them for doing so. Every time a state decides that accumulators, maximizers, and alternative funding programs are a bad idea for patients and they walk those programs back, that's how we measure the impact that we're achieving. And if you want to join us in achieving that impact, I'd encourage you to follow me on LinkedIn or sign up for our weekly newsletter.
Awesome. So we've got engagement, earlier detection, earlier diagnosis, community impact measures, citing research, and also the impact of policy.
It's a fantastic summary.
That's and it's a great holistic way to measure impact, right? Across all the areas we've got to be working on. So with that, I'm actually going to open it up to all of you, the audience in the room, for any questions that you have for our esteemed panelists. I think there's microphones floating around. Over here. Thank you.
Good morning, panelists. My name is Catherine Ames. I'm with Fierce Hope Patient Advocacy and Consulting, and my question is for Uché. I'm asked to help improve health equity initiatives quite a lot, especially in clinical trial recruitment, but often interest in my audits and landscape assessments, which are laced with health equity initiatives, feel performative, as in the clinical trial ends up with mostly white male participants, typically because underprivileged communities in San Diego cannot afford to take time off of work. So in a question for Hope, can you give me a case example of how your work has made a difference in a clinic or health system where a system has actually taken your feedback and permanently changed as a result? Or are you encountering and still up against performative interests in your work? Thank you.
It's Uché. You're welcome. This is ongoing work that we've been doing. I have to say that, when we step back and look at, clinical trial enrollment, we know that a lot of it, actually, there's a lot of data that shows that when you explain to, especially communities of color, what the benefits are of clinical trials, they're actually more likely to want to sign up to be participants of clinical trials than their white counterparts, because they actually see the benefit to the community. And so, I think a lot of the work that we've been doing is making sure that organizations that are involved in recruiting patients are really aware of what the barriers are. There's that trust piece, but the other piece is more practical. Like, are we compensating people in just in different ways? Are we making the time that they are available also, in alignment with when they need to show up? Are we providing transportation? And so, we have actually had probably 2 successful engagements with clients who have taken our feedback. I have to say, this current moment that we're in right now obviously is quite challenging because Some organizations are deprioritizing that importance, but we know that when we have diversity in clinical trials, we have better outcomes.
I would add to that, our qualitative and quantitative research has shown people aren't being asked. So
right, that's the other piece of it. So when they have studies that actually, are saying, would you participate? They will. But then the other piece of it, as you're correct, is that they're not asked to participate.
And then the other component I would say with the patient in mind is having patients involved from the beginning in clinical trial design. So how many times are they having to go into the clinic? Do they really need 15 blood draws versus 10? Just that sort of thing, and having patients involved from the very beginning will likely impact uptake and participation.
Love that. Another question? Oh,
Well, I'll give two answers. One, we were somewhat involved, but I don't want to suggest that we were the only ones. Early in the days of the COVID-19 vaccine, it was very, very clear to many, a lot of politics around it, so leave that aside for a second, that those really at risk were older adults and immunocompromised patients. And therefore, having older adults, let's say 50, 55 plus, or even 60 plus, in COVID-19 vaccine trials was essential. And the innovative companies did that. The second I'll refer to, which we had nothing to do with, and I personally had a little bit to do with, but I think is probably the best example, if I understand fully the question, is HIV/AIDS in the 90s. I mean, the HIV/AIDS patient community figured out how to be centrally involved in everything having to do with the development of the medicines, which led to better clinical trials, better clinical outcomes, their engagement from even before day one. In oncology, it's done a little better than many other areas still today. We recently had a set of roundtables, Global Coalition on Aging, with the Alzheimer's space. And we looked at HIV/AIDS and oncology as examples where engagement early on has been good for everyone, including the patient, but good for everyone. And it's really critical, because then that leads to what indications you get. And I mean, having early engagement, early involvement with the patient community, with the at-risk community, is a reform we should be looking at around the world.
agree.
Sorry.
Agree. No, appreciate that. I think we have another question up here.
Saren Rothberg, stage 4 cancer survivor, 3+ decades. And thank you. I always say, if God's looking down and people do applause, is God going, should I get a wave for that? Because this is 3+ decades on that. Okay, so I'm sorry I was late, but I want to just quickly ask, and then I'll ask my question. Did you cover artificial intelligence and the impact on patient outcome? Okay.
We have not.
So 2019, I wrote the first study on cancer survivorship using artificial intelligence and presented at AACR, it's published. But what I saw was that in not even 10 seconds when the press release hit call for participants, that it was for stage 3 and stage 4 cancer patients, women from 24 states and 10 countries immediately applied to be in this. And the outcomes, which scientifically studied, the outcomes were so measurable and so important, and their reaction and the diversity of the population was so incredible, and the ease of which, how they could participate. So we did a second study, and that study, we learned a lot for the second study, but I'm just saying, I think that, I hope all of you, if I can talk to you privately, we can talk a little bit about how it was so impactful. And AACR said it changed cancer research forever because it was so simple and so inexpensive.
Yeah, I love that comment and
AI.
commentary. I think that's a important place for us to continue to think about is like, where do the advents of new technology allow us to have solutions that have been really hard to solve for long times? How does it allow us to have access, better engagement, higher quality, systematized ways to understand holistic care? So I think it's the right push, and I'm sure that's coming up in the organizations that you guys are leading as well. Yeah. I want to just do a time check with the,
It says,
5 more
it
minutes?
says
Okay.
14. Oh,
No, I think
that's not right.
that's why I'm, that's why I'm checking. 2 more questions? Okay, we got 2 more questions. We got a question right up here. Thanks.
Oh, so that's not right.
I don't know what.
Hi, everyone. Just sort of to piggyback off of the AI, it's interesting that when I got the invitation to attend this, I was in the hospital with my husband and out loud said, I really want to do more work in patient advocacy. Right across the river, we live in Queens, but did not want to go to a Queens hospital after negative experiences and ended up on this side of the water. And it was just interesting to see night and day some of the care, the hospital teams, et cetera. As far as AI goes, I'm wondering how you guys feel about the usage when, you don't know what you don't know. I've been hospitalized multiple times because I have Crohn's disease. I've had 2 bowel resections. My father has had heart conditions, so I'm like the family advocate. But then juggling 3 kids and I step out and I need someone else to be there as my husband's support. And his mom, to him, was not the best advocate because she just simply did not know what to ask. So when you're thinking about AI and safety measures and giving your personal information to it, what do you think is good and bad and what should patients be looking out for? Because if you don't know the questions to ask your doctors and your teams, how can you challenge them? I often tell, I do content creation and tell my audience that you shouldn't feel subjected to keeping your questions back because someone has on a white coat and a stethoscope. If you fear something is not right, or in my husband's case, he was being discharged, but his white blood cell count was still going up. And I knew from my own experience that that's not a good sign. And they said, well, if he looks good, it's okay. And I'm just like, no. And then it's like, the checklist that you all go through and you check the boxes, and sure, on the surface, all looks well. But if you don't know, I just don't know how patients are able, or caregivers are able to support their family members. And just so what are the pros and the cons of using AI? I saw something you shared about the biases that AI are already picking up, which sucks because it could be such a useful tool to people. But if we're already plugging in the negatives that we as humans already have, then what benefit will it do us?
That's great. Well, I think Mike has maybe a couple of points on this, and maybe Dr. Blackstock
Yeah,
too.
so I won't speak to AI per se, but I will say, again, going back to our experience with Engage with Heart in Baltimore, these community health ambassadors and many in that space become advocates for the community, they become advocates for their neighbors. And as we've all been saying, starting at the local level, the community level, is so critical. As I say, I will not comment on AI for the moment, but I think what I take away, the most important thing I take away from your question is how does one manage advocacy for oneself or one's family? And the community can be part of that, and we've seen that a sort of unintended outcome, as it were, is exactly that in this Engage with Heart program in Baltimore.
Yeah, and I think that creates opportunities for us to continue to upskill and support community health workers with AI tools and patients in that way as well. But Dr. Blackstock, some of your thoughts?
Just to compliment what he said, just on a broader level, your concern is very much appreciated. I think, as we know, the use of AI is inevitable and that we have to be very intentional about it. I think about this study that came out in Science a few years ago that showed this algorithm that hospitals and health insurers were using to allocate care to complex ill patients or chronically ill patients was actually giving fewer resources to Black patients who are actually sicker. and that was because the data set that was being used was biased, and then they were not acknowledging the structural barriers that Black patients had to face to even access care to begin with. So, definitely there's the advocacy piece. I think, on the patient level, using the support of community health workers and community ambassadors and making sure that they're aware of how do we advocate for, these AI tools, in our care. But the other piece is the burden is on us and on the health tech companies. One of the things that we're doing, advancing health equity, is partnering with health tech companies around inclusive product design. And part of that inclusive product design is thinking about, what are the data sets you're using, and what are the other kind of structural barriers that you need to think about to make sure that this product doesn't perpetuate more harm.
Take the microphone down.
Just one thing about the AI. So we used a HIPAA compliant app so that, information wasn't going all over the internet. It wasn't protected. So anybody that's going to do it, I would suggest you use something that's HIPAA compliant.
It's great.
For safety.
And I think whether our organizations are focused in patient advocacy, our organizations are focused in the medical community, in policy, in research, in community outreach, whether we're a manufacturer, it's our job to start to really invest in how are these tools very powerful and powerful for good in the outcomes we want to drive, but we're all coming at it in different ways and continue to shape it. So really appreciate that question.
Could I just add one thing?
Yeah.
Okay, George.
I'm over here.
Yeah, okay.
One thing.
Yes.
So another resource that's available for patients are patient advocacy organizations. So in cardiovascular, for example, you have Mended Hearts or you have Women Heart. If you know who it is, they can help you. The National Blood Clot Alliance, who for VTE and pulmonary embolism, they like to say, we know the patient because we are the patient. So if you go to them, they can help you with the questions. They can help guide you, and people are there. There are many different organizations, the oncology, there's community, there's a lot of them. So just something else for people to be aware of. Thank you.
Thanks, George.
We have the one last question in the room. Do you have a microphone?
No.
Do we have a microphone
Maybe you
over
can
there?
come over.
Oh, sorry.
So I appreciate that woman asking about, like, what questions do you ask? And I wonder if there is some kind of document out there that can be given to patients to help them to answer those questions. And I hope I'm a computer geek, but I hope we don't forget that there are a lot of people who still don't like using their telephones. So
Sure.
to give them an app to find information is fairly difficult, and that's we can't forget those patients that need that kind of help. Because when you go into a hospital, everyone's really busy. Yeah. So I just want to
and I think
keep
that's
that in mind.
a good opportunity, again, for patient advocacy organizations. I can say for breast cancer, we have an endless list of a document called Questions to Ask Your Doctor, just that, and it's something you can print off. It's something that you can access via the internet, but many health advocacy organizations have the questions that you should ask, because again, when you're navigating a diagnosis, there is a lot of information thrown at you all at once, and it's hard to think through all the questions that you should be asking. And so would just again a pitch similar. Look at existing resources from trusted patient advocacy organizations.
Wonderful.
Katie, I see two people who really want to ask questions, one there and one here.
Yeah,
Okay.
I'm sorry. I know it's
one.
pressure. I know.
The patients have spoken.
I just have
and we need to listen to them.
Hi.
Yes.
Hi, I'm Lauren.
Hi. Okay. Is this on? Oh,
sorry.
Or you both will be
Just
able to go.
One quick question. So, hi, I'm Lauren Rotolo. I'm a patient advocate. I have a extremely rare disease called McCune-Albright syndrome, and there's less than 5,000 of us worldwide. So we're all talking about, everybody here has, something rare, no matter who we are and what we may have. But when you really have a rare disease like mine, even your patient advocacy groups aren't they're somewhat helpful, but they're not, because the doctors aren't educated. So many times you have to educate the doctors. And a lot of times when you walk in that door, talk about trust, you have to trust in yourself 100% because you are more educated than the doctor. And your diagnosis, they know, like for my disease, they call it a board disease because they heard about it on their boards and then they've never seen it again. And so, you know, any advice that you all may have for people that have like truly rare diseases and navigating the healthcare system. I've done it for almost 50 years because I was born with this disease. But it's something that I do every single day. And as the president of my organization, I really try to help people. But when you talk about how 1 in 5 Americans don't have health access, you know, I'm lucky that I'm here in New York City, but we have patients, you know, around the country and around the world that their doctor has never even heard of it, and they have to drive, you know, 50 miles to see just a GP.
Thank you, Lauren.
Any comments or on navigating rare disease?
I mean, not rare disease, and I hate to always put it back on the shoulder of the patient because I don't think that that's fair. But you know what we often advocate for our patients and our advocates is not to take the first response or first answer as the final answer. You know, you're empowered to push back. You're empowered to demand more. On the policy lens, you know, we learned a lot during COVID, and there was a lot of use of telehealth and, you know, access to providers that might not be in your state. And those were flexibilities that worked then, but now we're getting pushback. And so extending those
they
flexibilities.
won't do telehealth today, out of state.
I just want to quickly say thank you, right? Because when I was in government, I would frequently meet with patient organizations, and they're not all the big nationals. They're not all the logos that are designed by the good PR firms. And people like you trying to figure out more about something that others don't know and connecting with other people, like that's what creates the movement. That's what creates the information sharing. And small communities of people living with rare disease partnering up with other organizations that serve as umbrellas, like that's how change happens. So I just wanted to say thank you for doing the work that you did.
All right, we'll go with one last question in the room.
Sure, thank you. Christine Van Reesveld, I'm a patient advocate. I work with multiple organizations, including the Light Collective. Oh, speak up. Can you hear me? Okay.
Yes.
Work with multiple organizations, including the Light Collective in our healthy community. I heard a few of you mention economics in the conversation, and I've been in many meetings where they've talked about data as the new currency, which to me, I think there's potential for that, but currency in the same sense is the same value for me as it is to you, right? And I don't see that happening in the conversation. So my question to you is, how might the future of individual data ownership reshape economic systems, especially if this could be the catalyst for one of the largest redistributions of wealth on Earth?
Great question.
I think the answer is within your question. So the answer is yes. And the other point I'll use that to make, and also perhaps relates to the earlier discussion, is that what we're seeing in many places, I'm a broken record here, but Engage with Heart is a good example, is a growing interest in healthcare, in the healthcare world, by those outside of the healthcare profession. So, you know, employers are increasingly as interested in the health of their workers as other parts of society. They need a little education, perhaps, but, you know, having employers as an advocate for a rare disease, we've, during COVID, again, that was an unusual moment of a global pandemic, but we suggested that maybe it's a time. Employers spent years creating chief information officers, chief technology officers. Maybe this is a time for a chief public health officer, because those health issues are sort of outsourced to the HR community, the human resources, and many of them are not trained or really competent to do that. So it's a broad way of saying that having a growing array of interest, both at the individual level and at the, use the vernacular, the stakeholder level, an employer, the caregiving organizations, trade unions in Europe in particular.
Well, I want to thank everybody today for coming to the inaugural Galien Patient Summit, our first discussion, first panel. A big thank you to our distinguished panelists, but a huge thank you to this audience. I think the level of engagement and question is amazing, and I look forward to the continued discussions today. So thank you.